Hi everyone and welcome to week 4. Today I'm going to go over a couple of slides related to diagnostic screening tests, which is going to be the focus of this week's assignment and discussion board. So there are a couple of other things that are discussed in your book chapters this week, but I'm going to specifically talk about screening tests, specificity, and sensitivity and how you calculate that and what it all means conceptually. In the past, I've had some students that have had a little bit of trouble with this, and it is confusing at times, so I really wanted to kind of show you some slides and examples and talk through some of these. So just to get started, when we talk about a screening test, this is going to be anything from a colonoscopy to measuring blood pressure, cholesterol, a hepatitis test, an HIV test. These are things that are going to help diagnose an illness or disease. So first I want to define what validity means in this situation, and it's the ability of these tests to distinguish between people who have the disease and who do not have the disease. There are two terms that have kind of a conceptual and a quantitative description of how to describe screening tests. So one is going to be sensitivity, and this has to do with how well the test can correctly identify people who truly do have the disease, whereas specificity is the ability of the disease to correctly identify people who do not have the disease. So you have two examples in this week's discussion board to choose from where I want you to calculate the sensitivity and specificity. For my example, I'm going to use a liver biopsy as an example. So one thing that you would use a liver biopsy for is to test for cirrhosis. So when you do this, you have a positive result or a negative result, and individuals could either be positive and have cirrhosis or negative. So I have a random population of individuals, 463 people, where, let's see if my mouse can come in here. So 45 people tested positive and truly do have cirrhosis, whereas 6 people do not have cirrhosis but tested positive. You have 7 people who truly do have cirrhosis but tested negative, and 405 people who do not have cirrhosis and truly tested negative. So when we talk about sensitivity, this is going to be the number of people who have the disease and tested positive. So we had 45 individuals who have cirrhosis and tested positive, and this is going to be divided by everyone who has the disease. So this gives you the percentage of people who truly have the disease and that tested positive. So in this situation, it's going to be 45 divided by 52, and so that's an 86.5% sensitivity. When you're calculating the specificity, this is going to be the percentage of people, of everyone who does not have the disease, how many are testing negative. So we have 405 people who meet that criteria, do not have the disease, and tested negative, divided by everybody who does not have the disease. So that's 411. So this gives us a higher specificity than sensitivities. So 98.5% of people who tested negative truly do not have the disease. So one of the things that we use this for and to think about is false positives and false negatives. So you are going to have some people who fall into that range of testing positive but do not have the disease, and testing negative and do truly have the disease. And there are a couple of consequences and something that you really weigh when you think about what diagnostic test to use. So first, you have a situation of false positives, meaning that people are testing positive but they are not actually positive. So usually this requires needing more testing, which can be expensive. It can be a psychological stress, and you're asking people really to come back in for testing when they may not be positive. And one of the biggest examples and kind of healthcare policy changes around this is mammography recommendations. So I think it was a couple of years ago, they changed the recommendation for having mammographies, I think either from 40 to 50 or 45 to 55. And the reason was that at a younger age, it's less likely that individuals are going to test positive for breast cancer. And when people do have suspicious mammographies, it causes a strain on the healthcare system. It's expensive. You're causing people to have more biopsies, lumpectomies, mastectomies. It is something that was controversial, but this is kind of the idea around health policy and what causes us to make these health policy decisions. When we think about false negatives, these are going to be people who test negative on some diagnostic tests, but actually have the disease. So you're missing the diagnosis and you're preventing people from getting treatment. And depending on the illness or disease, depends on kind of whether you want to take this risk or not. So one of the biggest examples is HIV, which is the work that I do, and you don't want false negatives because HIV is something that can be transmitted relatively easily and is dangerous, and treatment is very effective. You want to make sure that you're catching as many people who truly are positive as possible and not letting them slip through the cracks. So one thing that your book talks about is continuous variables. So we just talked about having a positive versus a negative test, but what if the test is something more continuous? So blood pressure, cholesterol, more numerical numbers. And this really comes, I'm not going to get into detail about it, but it really comes down to a would you rather. So there is a trade-off here between sensitivity and specificity. You can have a high sensitivity and catch all of those individuals with the disease, but you're also going to group in a lot of false positives. Whereas high specificity, you're going to make sure that you truly are identifying those without the disease as negative, but then you're missing some true positives. So where is it that you would rather fall? So one of the other things that your book talks about is when you have diagnostic tests is you're not going to do just one test. And you want to make sure that you're conducting tests that are appropriate for the disease that you're testing for. And two ways of doing this are sequential tests versus simultaneous testing. So in sequential testing, you're going to start with a cheaper test, a less invasive test, and those who test positive, then you bring them back in for a more invasive or expensive test, and that's more likely to have a higher sensitivity and specificity. So an HIV test is a perfect example of this. So the first test that's usually conducted is a rapid test. So in the image here, you can see it's a quick finger prick. Sometimes they do oral swabs, but those aren't used quite as much, at least in the programs here in Maryland. And the rapid tests are a quick stick on the finger, a little bit of blood, very inexpensive, very quick, and you can give people their results relatively fast. If that comes back positive, then you run a conventional or laboratory-based test. So that's when you're going to have to draw venous blood. So you're drawing blood from a vein and you're sending it into a lab to process. One of the other differences is for HIV is the rapid test these days. They're moving towards more progressive tests, but people are still in kind of the third and fourth generation tests, which means they're testing for antibodies. So this isn't the actual HIV virus they're testing for. It's the antibodies that your body produces. And if that comes back positive, then they will go for a more expensive antigen test, which is testing for the actual virus. A simultaneous test is something that's done more at the same time. So you're conducting both of these tests at the same time. They're testing for the same thing, and they may give you more sensitive or specific results depending on what the test is. So one example is going to be if you have a patient that comes to the hospital with chest pain and you are concerned about a heart attack, you might order both an EKG and run a blood test at the same time. So these things can ultimately get you similar results, but there are things that are not as invasive that you would need to do one and then the other, but rather can be run simultaneously. So the next two concepts are positive and negative predictive value. So they have both clinical and public health meaning. A positive predictive value is thinking about if we screen a population, or, at the clinical level, even if you're just screening one individual patient, and this population or individual tests positive, what's the probability that these people truly do have the disease? Negative predictive value is going to be the opposite. If you screen a population or one individual patient and they test negative, what's the probability that they truly do not have the disease? So if we go back to our example of liver biopsy, the positive predictive value is going to be the number of people who both have the disease and tested positive. So in this situation, we had 45, and this is out of every single person in our group that tested positive. So that's 51, which brings you to 88.2%, and the negative predictive value. So that's going to be the individuals who do not have the disease and tested negative. So these are our true negatives, 405, divided by every single individual that tested negative, which is 412, and brings you to a negative predictive value of 98.3%. One thing that I just want to make sure you all are aware of is you are obviously calculating these given results of a previous test, because if we are diagnosing people based on this biopsy, how would we be able to do this square? We would already have the results. So you're usually comparing this to a gold standard. So what's something that is well known in the field, very reliable and valid, and this is usually how it's used to compare newer technology. So that's the gist of diagnostic screening and how that's all calculated. So hopefully that will give you some perspective of how it's all done. If you have any questions, please feel free to post and ask the professor section or email me.